This video will outline a rehab plan for a swimmer with a secondary rotator cuff impingement on his right shoulder, an injury classified as dynamic instability in stage 2. The plan, consisting of 3 two-hour therapy sessions, will take the patient from injury to full return to activity of the shoulder. Between the 3 sessions, the patient will perform activities addressing the goals of stages 1 through 5 of the rehab plan. Each session will include the following types of movements: movements focusing on increasing strength in the shoulder, movements focusing on keeping the leg muscles and abdominal muscles strong, and movements involving cardio exercise to increase heart rate and stamina. Finally, each session will end with simple shoulder stretches that the patient continue practicing at home. The first movement we will be asking the patient to do in session 1 is a squat. The squats will be modified in different ways to allow for some focus on the shoulder region as well, but the intent of the activity is to get the whole body engaged so that the patient doesn't feel any intense pressure on his shoulder yet. The first type of squat will involve extension of the shoulder and arm when the elbow is flexed as the patient goes down into a squat. To do this, the patient will be told to first stand with his feet shoulder-width apart. His elbows will be at his side with his arms bent at a 90-degree angle. His hands will be held in a fist at his side. As he goes down into a squat, he will be told to extend his arms forward. The patient should keep his core tight as he lowers his body by pushing his hips back and bending his knees, all while extending his arms in front of him in a straight line. He should make sure that as he goes down, his knees do not go behind his toes and he is looking straight ahead. His feet should be firmly planted on the ground at all times, and he should make sure his knees don't roll forward. After a slight pause at the bottom, with his arms outstretched, he should slowly push himself back up to his starting position. As he comes back up, he will pull his arms back in a straight line so that his elbows are back at his sides. That will be 1 rep. This exercise will involve many muscles all over the body because there are many movements taking place. The flexor group, including the brachialis, the biceps brachii, and the brachioradialis, bend the arm by decreasing the angle between the forearm and upper arm to get the arm in a 90-degree angle at the sides. The brachialis is the primary flexor of the elbow and is found mainly in the upper arm between the humerus and the ulna. Then from there, the triceps brachii and anconeus muscles work to push the arm in front of the body and reel them back in as the patient does a squat. These 2 muscles act as the extensors of the forearm. Working together, these 2 muscles increase the angle between the humerus and the ulna and radius, straightening the arm until the olecranon locks into the olecranon fossa of the humerus at full extension. Altogether, these arm muscles, some of which originate in the shoulder, help start to increase the patient's range of motion in the shoulder. While all of that is occurring, the patient is also engaging his muscles in his lower limbs. As he is going down into a squat, 3 different areas of the body are being utilized: the hip, the knee, and the ankle. At the hip joint, many anatomical movements are occurring. On the sagittal plane, where the body is split between left and right, the hip is flexing and extending. On the frontal plane, where the body is split into front and back, the hip is abducting and adducting. On the transverse plane, where the body is split into upper body and lower body, the hip is internally and externally rotating. To get these things to happen, however, many muscles need to be contracted. The primary hip muscle involved during a squat are the gluteus maximus and the hamstrings. The gluteus maximus helps to stabilize during a squat to prevent abnormal movement of the pelvis and knee, while the hamstrings are active during the full squat movement. The two joints that make up the knee are tibiofemoral joint, where the tibia meets the femur, and the patellofemoral joint, where the patella meets the femur, also work during a squat. The tibiofemoral joint works in the sagittal plane of movement with knee flexion, and the patellofemoral joint allows extension and flexion of the knee. The primary knee muscles utilized during the squat are the quadriceps group. They shorten during knee extension and elongate during knee flexion. Furthermore, the primary ankle muscles that are involved during a squat are the soleus and gastrocnemius. They work through dorsiflexion and through plantar flexion during dynamic movements. Ankle mobility is important to perform a squat to help balance and allow full range of movement without heels coming off the floor to allow for depth in the squat. The same lower body movement will occur in our next type of squat with a slightly different type of shoulder motion. The next type of squat we will ask the patient to do will involve the shoulder muscles bringing the arms all the way up parallel to the floor as the patient goes down into the squat. Essentially, he will be elevating his arms. To do this, the patient will be told to first stand with his feet shoulder width apart. His arms will start at his sides with his palms facing behind him. As he goes down into a squat, he will be told to raise his arms slowly in a straight line. Again, as with the last squat, the patient should keep his core tight as he lowers his body by pushing his hips back and bending his knees, all while elevating his arms. He should make sure that as he goes down, his knees do not go behind his toes. After a slight pause at the bottom, with his arms elevated, he should slowly push himself back up to his starting position. As he comes back up, he will lower his arms back down to his starting position. That will be 1 rep. Because of the arm muscles this activity involves, it might be very painful for the patient to perform. He may or may not be able to elevate his arms all the way up parallel to the floor in the very first session, but this activity is designed to get the patient working hard off the bat so he knows how much work it will take to regain strength in his shoulder. The main muscles involved in raising the arm are located in the shoulder, specifically known as the rotator cuff muscles. 4 muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, make up the rotator cuff. It stabilizes the shoulder and holds the head of the humerus into the glenoid cavity to maintain the principal shoulder joint. Some of these muscles are involved in the action of raising the arm. For instance, the infraspinatus muscle helps with the raising and lowering of the upper arm. The supraspinatus, located at the top of the shoulder, helps raise the arm away from the body. Because the patient has an injured rotator cuff, this action will be quite painful when performed. However, it might not be completely impossible since other muscles are also involved. For example, the triceps brachii, a large muscle in the back of the upper arm, helps straighten the arm. The teres major helps rotate the upper arm. Lastly, the latissimus dorsi, a flat rectangular muscle of the back, helps the arms rotate as well as move away and closer to the body. The next exercise will allow the patient to take a break from his shoulder muscles and instead focus on getting his heart rate up. He will be asked to do a simple ladder activity, 1 foot in at a time. He will do this 4 times, each time getting faster and faster. He will start at one end of the ladder and run the entire length of the ladder, making sure his knees come up high and his arms are at 90-degree angles at his sides. Once he completes 1 rep, he will walk back over to the other side and begin again. The first time the patient may go slowly to ensure that his form is correct. He is looking forward with his upper body barely moving at all while his knees are flexed and come all the way up with every step. His feet should barely touch the floor as he increases his speed with each rep. In total, this exercise will take 5 minutes. This exercise is essentially a stricter running exercise. Since running is a repetitive exercise with no added resistance, it builds muscular endurance as opposed to strength. It works the following muscles: the quadriceps, the hamstrings, the gluteus muscles, the hip flexors, the abs, the calves, and the tibialis anterior. The quadricep muscles get built up whenever the knee is extended, when the patient lowers his legs, moving from a bent to straight position. The hamstrings flex the knees, causing the lower legs to move back towards the butt when the patient's foot leaves the ground and the leg starts moving forward. The glutes are involved with hip extension, when the thighs move from a position parallel to the ground to a position behind the body. The hip flexors get worked when the thighs move towards your stomach. The ab muscles contract to give support and balance to the body while doing this exercise. The calves help with plantar flexion while running when the heel is in the air behind the body. Similarly, the tibialis anterior muscle helps with dorsiflexion when the leg is in front of the body before the foot lands on the ground. The next exercise we will be doing in this session is a glute bridge. Although a glute bridge is an effective glute toning exercise, it also works the rest of the core, including the rectus abdominis, erector spinae, hamstrings, and adductors. This, once again, will take the pressure off the patient's injured shoulder and keep up the strength in other parts of his body. To perform a glute bridge, the patient should lie down on the ground. This particular type of glute bridge will be done with the help of an exercise ball, but the glute bridge can be done without any sort of equipment as well. The patient will lie flat on his back with his knees flexed and feet on the ball. His calves will be parallel to the floor and his knees will make a 90-degree angle. The patient will be told to squeeze his glutes, raising his hips until his body is in a straight line from shoulders to knees. It will feel as though the patient is pushing off the ball with his feet. Once he is up into the bridge, the patient will pause a second before once returning to the starting position. At no point should the patient's shoulders leave the ground throughout the glute bridge exercise. He can extend both arms out to his sides for extra stability. The wider he spreads his arms, the more stable his body will be. But, especially given the patient's injury, he should not push himself up with his shoulder and arm muscles. All the effort of this exercise is focused from the ribs down. The gluteus maximus, along with the gluteus medius and gluteus minimus, with its powerful hip extension, is the prime mover for this exercise. The hamstrings and hip adductors also assist, both for extending the hip and stabilizing the body. Glute bridges also engage the rectus abdominis and erector spinae, which stabilize the spine against extension and flexion, respectively. The rectus abdominis, in particular, works in an isometric contraction to help keep the pelvis from tilting too far forward. The patient's obliques are also involved during bridges. The next exercise will refocus on the shoulder area, but will be a little less strenuous than the squat exercises. The intent of this exercise is to once again increase the range of motion of the shoulder and make the patient aware of his body parts, which is working on proprioception. To do this exercise, the patient will begin on his knees in front of the stability ball. Making sure he is at a comfortable length away from the ball, he will place his palms on the stability ball. Slowly, he will extend his arms in front of him, pushing the ball away from his body. His palms should remain in contact with the ball at all times, and his knees should never leave the floor. His back should remain straight as he pushes the ball away from his body, and he should be looking forward. Once the ball is arm's length away from him, he will once again reel the ball back in and return to his starting position. This will be 1 rep. At its core, this activity is essentially just a push-pull exercise. Certain muscles are involved in pushing the ball away from the body, and certain other muscles are involved in pulling the ball back towards the body. When the patient is pushing the ball away from his chest, he is using the pectoralis major muscle, located across the front of his chest, the triceps, located at the back of the upper arms, and the anterior deltoids, located at the front of the shoulders. The opposite motion, pulling, involves the chest, triceps, quads, lateral, and medial deltoid muscles. By doing this exercise, the patient is engaging all of those muscles and building strength back in them. Because many of them originate or are attached to the shoulder, this exercise will also help to restore range of motion in the patient's injured shoulder. The last new exercise that the patient will be doing in this session is jumping up the stairs with bands around his ankles. Just like the ladder, this exercise will increase the patient's heart rate and stamina while making sure the shoulder muscles aren't the focus of the exercise. To do this, the patient will take the green band and put his feet through it, making sure the band rests just above the ankles. He will proceed to a staircase and jump on each of the stairs. The patient may use the guardrails to steady his balance the first time up, but once he gets the hang of the exercise, he should drop his hands and just use his momentum to help him jump up the stairs. As with all the other exercises, the patient should look straight ahead. One rep will consist of the patient jumping up each of the stairs until he reaches the top and then walking carefully back down. Many anatomical movements are occurring while the patient is jumping. Hip extension occurs at the beginning of the jumping phase, before the patient's feet leave the ground. Muscles involved in hip extension are the gluteus maximus, semitendinosus, semimembranosus, the long head of the biceps femoris, and the adductor magnus. All of these muscles are located in the upper leg or gluteal area. Knee extension is a movement of straightening the leg at the knee joint, occurring almost simultaneously with hip extension while the patient is performing a vertical jump. One muscle is involved in knee extension, the quadriceps femoris, which is made up of 4 separate muscles of the anterior thigh: the rectus femoris, the vastus lateralis, vastus intermedius, and vastus medialis. Another movement included in a jump is ankle plantar flexion, also known as pointing the toes. This is the final movement the lower leg performs before leaving the ground during a jump. The primary muscles involved are the gastrocnemius and soleus, or the large muscles in the calf. As said before, this exercise can be performed with or without arm and shoulder movement, depending on whether the patient is holding onto the guardrails. If arm movement is involved, it's typically performed as a final upward reach while in the air. This movement involves 2 types of motion in the shoulder: abduction and flexion. Muscles involved in shoulder abduction are the deltoid, supraspinatus, and pectoralis major. Again, some of these muscles are part of the rotator cuff that the patient has injured, and thus it might be difficult for the patient to perform this exercise without support from the guardrails. The second rehab session will focus on stage 3 of rehab. The movements that the patient will be performing in this therapy session will allow him to continue working on his proprioception, strength recovery, flexibility, and swim-specific activities. The first movement that we will be asking the patient to perform is a push-up with his hands planted on the exercise ball while his knees are planted on the ground. The patient should make sure that his arms are flat on the ball, pointing forward and under the shoulders. The abdominal muscles should be contracting, and the legs should be performing a flexion upwards with the knees on the ground. There are 2 phases to this movement: the pushing phase and the lowering phase. In the pushing phase, motions are occurring at the patient's elbow, shoulder, and scapula joints. In the elbow, extension occurs, powered mainly by the triceps brachii muscle. In the shoulder joint, horizontal adduction occurs. This motion occurs when the upper arms move horizontally toward the midline of the body. The pec major, deltoids, biceps, and coracobrachialis muscles contract during horizontal adduction. At the scapula joint, scapular abduction occurs during the pushing phase. This means that the scapula move forward as they round the back of the rib cage, a motion also known as protraction. The serratus anterior and pec minor muscles power protraction. Once the patient reaches the top of the push-up, he then must lower himself back down. In the lowering phase, the same muscles at work in the pushing phase are active, but this time eccentrically. For example, in the elbow, flexion occurs as the body is lowered, but with the triceps eccentrically allowing this motion. In the shoulder joint, horizontal abduction occurs, eccentrically controlled by the pec major, deltoid, biceps, and coracobrachialis muscles. At the scapula, scapular adduction or retraction occurs, which the serratus anterior and pec minor eccentrically control. For the next movement, the patient will be performing a wall sit to strengthen the quadricep muscles and give the shoulder some rest. The patient should lean against the wall with his feet planted firmly on the ground, shoulder width apart. His feet should also be about 2 feet away from the wall, though the optimal distance will be somewhat dependent on the patient's height. Once in such a position, the patient should slowly slide down, and while the patient is sliding down on the wall, his knees are performing a flexion. He should have his back pressed against the wall until his legs are bent at a right angle. This angle is very crucial because if the thighs are not parallel to the ground, the quadriceps will be bearing less load and the effectiveness of this exercise will be diminished. The holding position is called an isometric contraction. The patient's arms should be resting at his side. The patient's knees should also be directly above the ankles, and his back should be touching the wall at all times. When he returns to the starting position by standing, he is performing a knee extension and a concentric contraction is occurring. This next movement is a core rotation on an exercise ball, which will help with the mobility and muscle control in the core, which is essential considering that the patient is a swimmer. The patient should first lean on top of the stability ball with his upper back on the ball and his hips out straight in front of the body, with knees bent at a 90-degree angle. He should keep his body straight from shoulders to knees. Then, he should extend his arms out straight in front of the chest with the palms touching each other. The patient needs to then twist through the stomach and shoulders, rotating onto one shoulder with the hips up, keeping the feet on the ground and back straight. The prime movers during rotation-based exercises are the external obliques. The internal obliques and rectus abdominis also help produce torque and help fine-tune the movement. Once the patient is on one shoulder, he should twist through his abs once again to the other side. This will be 1 rep. This next movement involves the agility ladder again to keep the patient's heart rate up. The patient will be asked to perform an activity that is similar to the previous ladder activity. However, one foot will be inside of the square and one foot will be outside of the square. The patient will move up the ladder, doing a running motion. When he starts, he'll step with 1 foot at a time outside of the square and then do the same thing but inside the square. The patient will complete this movement throughout the entire length of the ladder, and when he is done, he will walk back to the start and begin again. The patient must make sure that his form is correct. He must be looking forward with his upper body barely moving at all, while his knees are flexed and come all the way up with every step. His feet should barely touch the floor as he increases his speed with each rep. The patient will perform the same exercise now, only this time with his hands. He will start off in a plank position and hands outside of this square, and he will do the same motion, one hand in, one hand out. This exercise will work the abdominal muscles and the muscles in the upper arm, especially the biceps brachii and the triceps brachii. The elbow will be somewhat flexed as the patient does this exercise, and his legs will be straight, trailing behind him as he goes down the ladder. This next movement is like the push-up on the stability ball. However, the patient's hands will be on a wall this time instead of a ball. The patient should still make sure that his arms are flat on the wall, pointed forward and under the shoulders. He should be standing upright, facing the wall, about an arm's length away from the wall. There is still a lowering and pushing phase to this exercise. In the pushing phase, motions are occurring at the patient's elbow, shoulder, and scapular joints. In the elbow, extension occurs, powered mainly by the triceps brachii muscle. In the shoulder joint, horizontal adduction occurs. This motion occurs when the upper arms move horizontally toward the midline of the body. The pec major, deltoids, biceps, and coracobrachialis muscles contract during horizontal adduction. At the scapular joint, scapula abduction occurs during the pushing phase. This means that the scapula move forward as they round the back of the rib cage, a motion also known as protraction. The serratus anterior and pec minor muscles power protraction. Once the patient reaches the top of the push-up, he then must lower himself back down. In the lowering phase, the same muscles that work in the pushing phase are active, but this time eccentrically. For example, in the elbow, flexion occurs as he lowers his body, but with the triceps eccentrically allowing this motion. In the shoulder joint, horizontal abduction occurs, eccentrically controlled by the pec major, deltoid, biceps, and coracobrachialis muscles. At the scapula, scapular adduction or retraction occurs, which the serratus anterior and pec minor eccentrically control. Finally, during the patient's very last 2-hour rehab session, we will be addressing the 4th and 5th stage of rehabilitation. Stage 4 will mostly include activities with the aim of increasing strength and agility. The 5th and final stage of rehab will allow the patient to return to full activity, in this case swimming, with pre- and post-practice support. All the while, we will continue to increase the patient's stamina and strength in shoulder and other parts of the body. We will start off session 3 with some med ball exercises. With this activity, the patient will be returning to full activity and full use of the rotator cuff muscle while throwing a med ball on the wall and catching it. First, the patient should stand about an arm's length away from the wall. He should stand in a comfortable position with knees slightly flexed. Picking up the med ball, the patient should bring the ball up above his head, arms extended up. The patient will throw the ball at the wall and catch it. As the reps go on, the patient can increase intensity or speed. He can change how far away he is from the ball as well to change the exercise's parameters. The patient will do this for 5 minutes, doing as many reps as needed during that time. This exercise is relevant to the patient because it involves a lot of the same motions and muscles involved in swimming. The phase of movement involved in throwing a med ball or taking a forward stroke when swimming can be divided into stages: cocking, acceleration, and follow-through. The very beginning of the throw is cocking. This involves abduction, external rotation, and extension. The muscles involved are the posterior deltoid, infraspinatus, and teres minor, which are some of the rotator cuff muscles. The main phase is the acceleration. It is propulsive in throwing and, along with the follow-through, is involved in the pull-through in swimming. The muscles involved are the anterior deltoid, pec major, latissimus dorsi, subscapularis, and teres major. Repetitions of this phase can lead to rotator cuff attrition, mainly the supraspinatus and biceps brachii tendons, attributable to impingement taking place under the coracoacromial arch, which is what happened to the patient. The last part of a throw is a follow-through, which is somewhat limited given that the range of motion in this exercise is limited due to the patient's closeness to the wall. Nonetheless, in this phase, the infraspinatus has a small role and biceps brachii have most of the activity. The next exercise that the patient will do in this session is a normal push-up on the floor. To do this, the patient will be told to get down into a plank position. When down on the floor, the patient should have his hands slightly wider than shoulder width apart. The patient's arms should be straight and supporting his body weight. With his arms straight, butt clenched, and abs braced, the patient should steadily lower himself until his elbows are at a 90-degree angle or smaller. As the patient increases his reps, he may be able to go down until his chest hits the floor. Either way, the patient should try to go down the same distance each time. The patient should try not to let his elbows go flying way out with each repetition. He should keep them relatively close to his body. Once the patient's chest touches the floor, he should pause slightly and then push back up until he is in the starting position, which is a plank. That will constitute 1 rep. Various muscles are worked during a push-up. The pectoralis major consists of 2 large chest muscles that make up most of the upper body. As the patient raises and lowers his body during the push-up, the pec major is doing most of the work to raise and lower his body. The deltoids are another big group of muscles. These are the shoulder muscles helping the pec major to push the body during a push-up. Although they are a weaker muscle group, they are crucial to all movements of the shoulder. The triceps brachii are situated at the back of the upper arm and help in extending the arm outward. It makes about 2/3 of the upper arm mass and is the most exerted muscle during push-ups. Other muscles include the serratus anterior, the coracobrachialis, and the abdominal muscles. The serratus anterior lies under the armpit at the back of the chest. These muscles are activated during a push-up, and doing regular push-ups strengthens the serratus anterior muscle, helping with smooth movements during exercises. The coracobrachialis runs from the shoulder blade to the upper arms. During a push-up, the coracobrachialis pushes the upper arm against the body, which is essential to perform a push-up. A well-developed coracobrachialis muscle is necessary for building upper body strength. Finally, the core strength develops as the abdominal muscles are engaged in a push-up. As the body is held in a plank position, the abdominal muscles help the body brace itself. Next, the patient will be doing a modified sit-up. This is to engage the shoulder muscles as well as the core area. The patient will be told to lie down on his back on the floor. A med ball will be placed above his head and his hands, which are outstretched above his head, and they should grab it. His knees should be bent and his arms should be straight above his head. His heels should be about 12 to 18 inches from his butt. As he sits up, the patient should bring the ball above his head and out in front of his body, trying his best to keep his arms extended the entire time. He should engage his core muscles and pull his rib cage together and toward his pelvis. His neck should be relaxed and his head aligned with his spine. At all times, his feet and butt should always touch the floor. While sitting up, the patient should raise his upper body until his back is off the floor. Once up, he should hold that position, then lower his back to the starting position. This target muscle of a sit-up is the rectus abdominis. It is one of the 4 main muscles making up your abdomen. It starts at the pubic bone and stretches in a straight line upward towards the ribs. Anytime the ribs are brought towards the thighs, as done in a sit-up, the rectus abdominis is being engaged. It is also responsible for controlling the tilt of the pelvis and the curvature of the lower spine. The assisting muscles, the iliopsoas, tensor fascia latae, rectus femoris, sartorius, and the obliques, are also essential to a sit-up. The iliopsoas runs from the lower ribs and across the hip and attaches to the femur. It assists with flexing the hip and rotating the spine. The tensor fasciae latae is a thin muscle running from the pelvis to the tibia. It assists with flexing the hip and moving the legs away from the center of the body. The rectus femoris makes up part of the quadriceps, and it assists with both bending the hip and extending the knee. The sartorius is a long, narrow muscle running diagonally across the front of the thigh. It assists with both bending the hip and the knee. The obliques are other abdominal muscles that lie on the sides of the torso. They assist with flexing, rotating, and bending the spine. The tibialis anterior is also involved in the sit-up. This muscle, which runs from the top of the shin bone down to the first metatarsal, helps flex the ankle. As the patient goes through the upward motion of a sit-up, he may feel slight tension through the front of his legs. This is his tibialis anterior engaging. While the sit-up does not strengthen this muscle, it does use it to keep the ankle stabilized. The last exercise that we will do with the ladder is jumping. Just like the other two ladder exercises and the other jumping exercise on the stairs, this will increase the patient's heart rate and build confidence and stamina. The patient will start at one end of the ladder and jump into each one of the squares, landing on 2 feet. His arms should be bent at a 90-degree angle at the elbow, and they should give him the momentum to jump up and down. As he is jumping, the patient should be looking forward. Once he reaches the end of the ladder after jumping on all the squares, he should walk back to the beginning and do the exercise again. In the span of 5 minutes, he should be able to do the whole ladder 4 times. As he is increasing his reps, he can also increase his speed. The patient's knees should come up together, and his feet should be on the ground for shorter and shorter amounts of times as he increases his speed. The same anatomy is happening in this jump as was happening when the patient was jumping up the stairs. Many anatomical movements are occurring while the patient is jumping on the squares. Hip extension occurs at the beginning of the jumping phase before the patient's feet leave the ground. Knee extension is the movement of straightening the leg at the knee joint, occurring almost simultaneously with hip extension while the patient is performing a vertical jump. Another movement included in a jump is ankle plantar flexion, also known as pointing the toes. The arm movement involves 2 types of motion in the shoulder: abduction and flexion, which include muscles that were once injured but now have regained their strength. Now to switch the focus back to the patient's shoulder, we will be utilizing tools called resistance bands, which will be attached to door handles. The resistance bands are used a lot in sports medicine for injury prevention and recovery. The goal is to work isolated muscles, in this case the shoulder muscles. The muscles will benefit from increased blood circulation and muscle strengthening, which will help speed up the recovery process. The patient will be performing a movement with these bands, which involves moving his arms in such a way that it resembles churning butter. So the patient will grab the handles and perform an extension of the arms forward. Then he will pull the rope from the lateral side of his body towards the medial side of his body. He will pull the rope towards his core and then bring it back to his lateral side. This will result in a horizontal circumduction motion, and he will repeat this motion 10 times for a duration of 15 minutes. The patient can either challenge or modify the exercise by making bigger or smaller circles, working his infraspinatus, supraspinatus, and teres major muscles, the rotator cuff muscles which were once injured. With the next movement, we are using the same resistance ropes as we did in the previous movement. However, this time the patient will be performing a circumduction with his arms. So he will grab the handles and pull one rope to the medial side of his body and one to the lateral side of his body. Starting with one arm, the patient will perform a horizontal circumduction with his hand, making small circles while still hanging onto the rope. Then with the other arm, he will repeat this motion. This will help the patient really work his shoulder and back muscles. Specifically, this exercise works the pec major, deltoid, supraspinatus, long head of the triceps, and the biceps brachii. The patient will be performing this exercise for 10 reps for a duration of 20 minutes. With the next movement, we are using the same resistance ropes as we did in the previous movement. However, this time the patient will be performing a circumduction with his arms. So he will grab the handles and pull one rope to the medial side of his body and one to the lateral side of his body. Starting with one arm, the patient will perform a horizontal circumduction with his hand, making small circles while still hanging onto the rope. Then with the other arm, he will repeat this motion. This will help the patient really work his shoulder and back muscles. Specifically, this exercise works the pec major, deltoid, supraspinatus, long head of the triceps, and the biceps brachii. The patient will be performing this exercise for 10 reps for a duration of 20 minutes. The final exercise that the patient will be doing with the resistance ropes is called shoulder flies. The patient should stand up straight with a handle in each hand. His feet should be a bit narrower than shoulder width apart, and hands should be facing his body. His arms should be slightly bent in the elbows, and legs should be slightly bent in the knees. The patient should then elevate his upper arms to the side until his elbows are at shoulder height. At the top of the movement, his elbows should be a bit higher than his wrists. Once the patient reaches the top position, he should hold for a moment and then squeeze his shoulders. After that, he will slowly lower the ropes to the starting position. The primary muscles used in this movement are side deltoids or lateral deltoids. Secondary muscles that assist the movement are rear and front deltoids, trapezius, as well as the forearms. The patient should lead with his pinky finger. He should keep his elbows pointed high while maintaining an angle of 10 to 20 degrees. The patient should try to execute the movement in a controlled manner without swinging the rope handles. The arms should be raised by shoulder abduction, which is lateral movement away from the midline of the body, instead of rotation. Now, to cool off after performing all of those strenuous exercises, the patient will be performing some stretches for the last 5 minutes of each therapy session. The patient can also do these simple shoulder stretches at home. The first stretch that the patient will be performing is circumduction of the shoulder. It should resemble tracing circles in the air. If the movement is too painful for the patient, then he can modify the stretch by either doing fewer circles or making them smaller. Both arms will be performing this action simultaneously to ease the shoulder muscles, especially the infraspinatus, the supraspinatus, and teres major muscles. The first stretch that the patient will be performing is circumduction of the shoulder. It should resemble tracing circles in the air. If the movement is too painful for the patient, then he can modify the stretch by either doing fewer circles or making them smaller. Both arms will be performing this action simultaneously to ease the shoulder muscles, especially the infraspinatus, the supraspinatus, and teres major muscles. The first stretch that the patient will be performing is circumduction of the shoulder. It should resemble tracing circles in the air. If the movement is too painful for the patient, then he can modify the stretch by either doing fewer circles or making them smaller. Both arms will be performing this action simultaneously to ease the shoulder muscles, especially the infraspinatus, the supraspinatus, and teres major muscles. The first stretch that the patient will be performing is circumduction of the shoulder. It should resemble tracing circles in the air. If the movement is too painful for the patient, then he can modify the stretch by either doing fewer circles or making them smaller. Both arms will be performing this action simultaneously to ease the shoulder muscles, especially the infraspinatus, the supraspinatus, and teres major muscles.